the implementation
Nigeria and China set for enhanced relations as President Tinubu embarks on state visit.
Managers of birth registration in Nigeria join forces to upskill data.
No new policy on minimum age of entry to tertiary institutions, Education Minister clarifies.
And good morning, Nigeria. Today we shall discuss the Mpox outbreak in the country.
Recent records show that Nigeria has 39 cases of monkeypox with 0 deaths, gratefully. And these data come from the Nigeria Center for Disease Control and Prevention, NCDC.
The NCDC says these 39 confirmed cases are spread across 33 states. Monkeypox, also known as Mpox, has been described as a rare disease that can spread from animal to man and from man to man.
And states with the highest numbers include Bayelsa with 16 cases, Cross River with 5 cases, Ogun 4, Lagos 4, Ondo 3, and Ebonyi with 3 cases.
Signs and symptoms of Mpox include fever, headache, body aches, weakness, swollen lymph nodes, and rash. This is our first conversation on the program today. But of course, talking about Mpox, we actually did have some guests some weeks ago. We didn't talk about it, but I mean, this is an updated version just so that Nigerians can be properly informed.
Indeed, and be guided as developments unfold. We will also take a look at cancer awareness and efforts targeted at upscaling data. Welcome to the program, the last for the week. We are reaching you on the network service of the NTA. I am Victor Azo.
Of course, we're strictly focusing on health today. I'm Henry John, my colleague Victor, to welcome you to the program. This is reaching you live on the network service of the NTA. Expect the news for a review with Chukudi Okulu much later. But for now, let's join Musa Abubakar for the morning news. Musa, good morning to you.
Good morning, Henry. Good morning, Victor. Here's the news. President Bola Tinubu departed Abuja for Beijing, China on Thursday, August 29th on an official visit. In a statement signed by a special advisor to the President of Media and Publicity, Joey Ngilani, it says President Tinubu will have a brief layover in the United Arab Emirates. In China, the President will meet with President Xi Jinping and will hold meetings with Chinese business leaders on the sidelines of the Forum on China-Africa Cooperation. The Nigerian President will be accompanied by senior government officials on the trip. Meanwhile, President Bola Tinubu has urged the newly appointed Brazilian ambassador to Nigeria, Carlos Jose Arias, to prioritize the establishment of direct flights between Nigeria and Brazil. The president made the request while receiving a letter of credence from the Brazilian ambassador. President Tinubu reiterated his discussions with President Luis Lula da Silva of Brazil on the matter in February on the margins of of the African Union Summit in Addis Ababa, Ethiopia. The President expressed Nigeria's commitment to working closely with Brazil to strengthen bilateral relations and advance shared priorities, welcoming the country's presidency of the G20 in 2024. In the discussion with President Lula da Silva, there was also agreement to energize the economic development of the two countries, looking forward to continuing collaboration. President Tinubu also received a letter of credence from Ghana's High Commissioner to Nigeria, Vice Admiral Seth Amwama, while commending Ghana's active participation in ECOWAS. The President reaffirmed Nigeria's commitment to strengthening relations with its West African ally. Nigeria's First Lady Oluremi Tinubu has called for a strategic shift in the registration of significant life events such as birth registration for every Nigerian child, for them to have a name and nationality recognized under the law. She made the call at the official launch of the Renewed Hope Initiative project to accelerate birth registration at scale in the country. The project, in partnership with the National Population Commission and development partners, aims to mobilize leadership and political commitment from critical stakeholders to ramp up birth registration, leveraging community participation and technology.
Of our social security. Our children, the treasure of our nation, should be guaranteed their rights and privileges from the onset. A well-functioning civil registration and vital statistics safeguards these rights and ensures no violation goes unnoticed.
The Minister of Education, Professor Tahir Mamman, says there is no new policy on the minimum age of entry into tertiary institutions, rather a fortification of an existing one. The Minister was speaking during an engagement with leadership of the Congress of Nigerian University Academics. He says the federal government only seeks to sanitize and further strengthen the system, noting that the university system has become polarized with underage students, which sometimes makes the job more tasking for university workers. The federal government is concerned over issues of kidnapping and other security challenges confronting the country, and it is working hard to secure lives of citizens and ensure those abducted to regain freedom. These were words of assurance from the Minister of State, Labour and Employment to leadership of the Nigerian Association of Resident Doctors, while appealing to the doctors to call on the ongoing 7 days warning strike. The minister gave the assurance during an engagement with leaders of the union in Abuja. As the news at this time, Good Morning Nigeria continues with Victor Anieri after the commercial break.
Nigerian, brought to you by the National Orientation Agency, NOA.
When you hear about the domestic energy and US dollar bond, Do you think of a win-win investment or an opportunity to be a part of the nation's development? I see them all. The domestic FGN US dollar bond is low risk, higher returns, and secure. Invest with a minimum of $10,000. Download the form from www.cmo.gov.ng. Complete and submit with your evidence of payments to any of the issuing houses, financial advisors, or receiving banks. The offer is open to Nigerian residents, Nigerians with savings abroad, Nigerian diaspora, and institutional investors. For more information, consult your bankers or financial advisors on how to invest in domestic FGN US dollar bond. Be part of something greater. The domestic FGN US dollar bond. Let's prosper together.
Relief is coming. More wages, reduced costs. Nigeria's national minimum wage is now 70,000 naira and it will be reviewed every 3 years. The federal government will commence immediate implementation and state governments have been encouraged to follow suit. With the presidential CNG initiative, transport costs are coming down. Are you a car owner or a transporter? Visit www.pcr.gov.ng to find out how you can benefit from switching to CNG. This is the renewed hope. A new edition of TV Guide is out.
This time, we got up close and personal with the transformational legislator, the Deputy President of the Senate, distinguished Senator Barrow Jibrin.
We created a difference in terms of implementation through interventions that have brought an unprecedented infrastructure development to my area.
This edition is a compendium of mind-blowing stories for your reading pleasure, ranging from technology, entertainment, economy, media, politics, family, and lots more.
It is indeed a park of excitement as we take you through every aspect of life. Pick up your copy and get abreast with issues and trending features within our space.
TV Guide, very incisive, very educative and compelling. Grab a copy at the vendor near you or any NTA station nationwide. TV Guide, your indispensable companion.
Nigeria means a lot to me.
And Nigeria means peaceful cohesion.
My country.
We're going to pray and then hopefully we will come to understand that unity of purpose, unity of living together.
Our ethnic beliefs and background and culture is our strength.
Ever since the administration period of 1914 to date, about 109 years ago, the people of Nigeria live very peacefully with one another.
I think diversity helps a lot to enhance robust development in Nigeria.
All over the country, you have so many ethnic groups, over 250. That is enough to tell you that this is a blessed country. And, God has kept, together as one indivisible entity.
Thanks for staying with us on Good Morning Nigeria. And up next is Newspaper Review.
Chukudi Okulubaja with us this morning. Chukudi, good morning to you. Good to see you.
Chukudi Okulubaja with us. How are you, Igbo man? More Igbo. How are you, Victor?
I'm all right. Good morning, as happy as I can be.
The rain is having back on what it missed. It lost, rather. And we're happy for it.
It was torrents last night.
Good to be here.
All right, let's see what the papers have. Looking at the lead story this morning, we have the New Telegraph with us, and it leads with striking doctors who invoke no work, no pay, says federal government. Riders reiterates it's been working with NSA and others to ensure immediate safe rescue of Dr. Popola to provide 50% electricity subsidy for public hospitals, universities, others. Details on pages 2 and 3 of the New Telegraph. Above that lead story on the front page of the New Telegraph this morning, we have Nigeria won't get things right without experienced people in power. That's according to Shekarao. Canada ends policy allowing visitor visa holders to apply for work permit. That's on page 4. I'm sure a lot of Nigerians want to see this. Abia, Kalu forwards OT's claim on Arochukwu Ohafia Road project. Details of that on page 3. And Cherry One for Women. This is coming from the IMF. More women leading record number of central banks. That's on page 25. Quickly away from all of that, below the picture stories, right here we have Ajero to police. NLC can't be intimidated. We have nothing to hide. That's on page 4. Next to that, Nigeria kidnappers collected 1.048 billion naira ransom in 1 year, according to a report. Terrorism will end day Nigerians say no to it, according to the defense headquarters. Kaduna soldiers engage bandits in gun battle, kill 8. All right. Let's leave all of that, and of course, you want to know that the president is in China. Or rather, will be in China much later. Tinubu leaves for China on official visit. That's on page 4 of the New Telegraph. Let's see the blueprint. The blueprint has the food crisis as its lead story. Crash food prices in 1 month of face sanction. Federal government warns retailers. Rider. Import charges, high bank interest, rent increment are challenge, according to traders. All right, interesting. You want to see what's going on. All of that. But because let's look below that now. Below the picture, sir, we have Edo Guba, parties to sign peace accord September 12. IPAC urges neutrality. The writer, Gandhi 13th NCEC with lawsuit over Enugu APC factions. Of course, Tinubu urges Nigeria, Brazil, collaboration on aviation. It's also right here. And the higi between the NLC and the police is also right here on page 7 of the blueprint. 4 suspects arrested over use of EFCC chair's name to extort $1 million. 4 suspects arrested over use of EFCC chair's name to extort $1 million. That's on page 6. And finally this morning at the top of the blueprint, troops neutralized 1,166, arrested 1,096 suspects in August, according to the defense headquarters. That's on page 19. Victor.
All right, and from the Leadership Friday comes this story, read earlier though. Alleged terrorism financing. Labour talks tough after Ajero's visit to police, saying we won't be intimidated and external pressure behind my travail. That's according to the NLC president. And then just beside the picture story here, you have public hospitals get 50% electricity subsidy. You can get details of that on page 7. And above the masthead of the nameplate, Nigeria accepts crypto, grants to operators interim approvals, page 26. And $1 million fraud EFCC arrests syndicate impersonating Olukoyede, that story is on page 17. And then 6 states spend 160 billion naira on airport projects. That one is trending on page 2 here. I think we should leave it at this, but that's after we take this last strip on the front page of the Leadership. 1,166 terrorists killed, 721 hostages rescued in August. That's according to Defense Headquarters, and the story is on page 6. And Sharia Commission invites cleric over gay meeting, page 7. Chukode.
Let me start from a positive note. Yeah, lives were lost. But these were criminal lives, people who have been reigning terror of their fellow men. So we commend the security forces, 1,166 said?
Yes.
That is commendable. The Pikin will say, Mama no go sleep.
He himself no go sleep.
The child itself will not sleep while he's disturbing his mother. It has to stay awake, isn't it? To get sense. Now, moving away from that, the DHQ is saying that terrorism will end when Nigerians, the day Nigerians say no to it. Yes and no. Yes, in the sense that see something, say something has to work for the security forces to work maximally. They can't become ghosts, spirits, to get information to go after those people who are troubling you. Yeah, people could say the reason we're not speaking up is that when we leave, we have their mercy and all that. They still have to find a way. Otherwise, it will become an intractable problem, going on and on and on. No, because at the end of the day, it is not the citizens, the government to ask how far they have fared in the war on terrorism. It is the security forces. So we have to balance views there. Maybe the argument the DHQ is making is like what people tell you concerning a society that is crime-ridden. A top policeman, he became an IG when I was still in Lagos. I interviewed him. He was a commissioner then. He told me that the society gets the kind of police force it deserves. I felt it was harsh coming from him. But later I knew what he was talking about. When Nigerians embark on a pilgrimage to a politician's house, anytime they come from Abuja, they are asking for their share of the national cake. So how correct are you when you say the politician should not, get his hand on the till, steal some money so he can satisfy you their constituents at home? Everyone needs to be part of saying no to Maladi.
But I'm not sure yet how that, explains that Nigeria, the people get the kind of police force that it deserves. I'm not sure. You're talking now about politicians. If you are talking about the police force, how does that work? How do the Nigerian people deserve it?
I've said it already. If you put 500,000 policemen to police a community of 1.5 million people who do not want to keep law and order, the police will not succeed. That's the point I'm making. So what it means is that everyone should be part of fighting, I call it Maladi when I started off. If you put 500,000 policemen to police a community of 1.5 million people who do not want to obey the law, they will succeed. That's the point I'm making. Do you get it now? And I just mentioned the politicians as well. We are part of the reasons the politicians are corrupt. When you point one finger at people, how many point back at you? I am not in any way commending, continuing, continuing disorganized society. But we are saying that when we are really serious, everyone will become part of the band.
I'd like you to explain that. How are we responsible for how corrupt our politicians are? How is that?
You were studying for the JAM.
I'm not yet 18, by the way. I don't qualify.
Pause to think. This comes naturally to you. You're happily mischievous. Yes. We were saying that if we form the habit of expecting a politician to come and lavish money on people anytime they go to their constituents, you're not asking that politician to stay within the pecuniary benefits that are legally given to him. That's the point I'm making. Some of us will tell you we don't go to politicians. Never.
Even if you don't go to politicians, the Nigerian politician will be. Are you trying to say that the Nigerian politician does all he or she does because of the people?
Let me finish your statement for you. Even if you don't go to politicians will go to you. You must you accept them.
Even if you don't accept them, they will still do what they will do.
No. These this question of this attitude of thinking that only government is wrong is the reason Black Africa does not move forward. I am serious about it.
Maybe the reason why people expect their politicians to lavish them with much,
because they have so
because
much.
they know that they have so much. They know that they earn so much. They know that
you are reading your Quran or your Bible upside down. We have tried not to make this a religious.
Anyway, let's talk about the public hospitals.
By the way, if I go home now, nobody's going to ask me for anything because they know my salary is 70,000 and.
A politician.
Let's look at this. Public hospitals get 50% electricity subsidy.
That is part of reducing the cost of running the hospitals.
Yeah.
It is going to be
I hope that impacts.
in case of Uniben.
True.
You understand?
I hope that impacts medication, most of which are now no longer available even on the insurance scheme.
Even the essential drugs.
Are not available on insurance anymore.
What do you call it? Sugar level, what do you call that? Diabetes drugs, metformin, and the rest of them are climbing. That means that those who can afford it, we have signed a death warrant. And when they die, we go there to say, sorry, oh my God.
That's why I said I hope it impacts, the medication, provision of the medication.
Victor.
Most likely, right?
Yes. Thank you so much. Have a great weekend.
Yeah, but I want you to smile more. I didn't quite see the ray that
I would smile when you bring some of your harvest. I guess harvest.
Oh yeah. You're going to get some.
Okay.
I made the promise on air. I'm going to deliver it on air.
Mr. John.
Stay with us. We'll take a break. When we come back, we'll get into the conversation.
Imagine a world where your potential isn't limited by your bank account, where your financial dreams can become reality. That world is here with the Nigerian Consumer Credit Corporation Scheme, Creditcorp. Creditcorp is one of President Tinubu's initiatives designed to put the power of consumer credit in the hands of working Nigerians. Here to help you achieve your goals, whether it's providing for your family or expanding your home or business. Visit www.creditcorp.ng today for details. This is the Renewed Hope.
NTA Television College Jos, with a pedigree of producing indelible professionals in the media space and an affiliate of the prestigious Ahmadu Bello University, Zaria, for the award of degree in mass communication, calls on prospective candidates to leverage on the following courses it offers for 2024-2025 academic session. BSc Mass Communication, those with minimum admissible score of 180 and above who sat for the 2024 JAM/UTME and direct entry, while 100 to 179 minimum admissible score can apply for the National Innovation Diploma NID in Film and Television Production, Broadcast Journalism and Television Engineering. For more inquiries, visit our website or call 0803 383 4343. Announcer, Registrar.
For you in a romantic relationship.
Trust.
I would say small d. Mama, you shy? Can see. We are cooking. No pressure. Pressure to what? No pressure. Two strikes. No pressure. Name a way most people get over their ex. Pray. Sorry, sir.
Join body with your football party, Go TV.
for correct goals and action. Sharply connect on top Goal TV Max with 7,200 naira to torchlight La Liga, Serie A, Europa, and select Premier League games live on top Super Sport. Goal TV, love it.
You have to move from the point where you protect and defend your religion to a point where you also recognize the rights of the other person, of the other religion, and protect it. So if I am protecting my own territory and my own people and trying to emphasize their rights and protect their rights, I should also be thinking about how to protect the rights of the others.
Both Islam and Christianity recognize and defer to God, and both recognize the temporariness of the life of this world, and that ultimately we all go back to God for the day of reckoning, when everybody will render an account of his life on this temporary abode.
Right, welcome back. It's still Good Morning Nigeria, live on the network service of the NTA. And to kickstart our first conversation this morning, which is on Mpox, the outbreak of Mpox in Nigeria. Let's quickly see this background report put together by our correspondent, Oyeyemi Ajayi.
According to the National Center for Disease Control, NCDC, Nigeria has 802 suspected cases of monkeypox, also referred to as Mpox, with 40 confirmed cases and no death yet recorded in 33 states of the Federation. As it is, 30 local government areas of 19 out of the 36 states of the Federation have confirmed cases of the virus. States with the highest number include Bayelsa with 16 cases, Cross River with 5, Ogun and Lagos states have 4 cases each. Ondo and Ebonyi states have 3 cases of the virus. Mpox, a viral infection that causes flu-like symptoms and pus-filled skin lesions, was declared a global public health emergency on 14th of August this year by the World Health Organization after an outbreak in the Democratic Republic of Congo of a new version of the virus known as Clave 1b was found to have spread to other countries. Some of the known signs and symptoms of Mpox include fever, headache, body aches, weakness, swollen lymph nodes, and a rash. It is a rare disease that can spread from animal to man and from man to man. On the 27th of August, the United States government, through the U.S. Agency for International Development, USAID, donated 10,000 doses of the monkeypox vaccine to the government of Nigeria to support its efforts in responding to the current Mpox outbreak. The vaccine is a 2-dose primary series for use in persons who have never received a smallpox vaccine and a single booster for individuals previously vaccinated with a smallpox vaccine. Due to limited doses, the government of Nigeria has prioritized 5 states, Bayelsa, Edo, Cross River, Lagos, and Rivers, with the highest burden of Mpox cases. The vaccine will be given to those most at risk of Mpox, including close contacts of Mpox cases and frontline healthcare workers, with a provision for reactive vaccination in other states as the need arises. Now, what is the level of preparedness of the government to prevent the wide and wild spread of the virus? Also, is Nigeria looking at accepting vaccines from other manufacturers, as well as plans to produce the vaccines locally? Our guests in the studio will fill us in with answers to these questions shortly.
All right, many thanks, Oyeyemi Ajayi, for that background report. And to begin our conversation this morning, let me introduce here in the studio Dr. Garba Ahmed Rufai, Director of Disease Control and Immunization, National Primary Healthcare Development Agency. A pleasure to welcome you to Good Morning Nigeria.
Thank you. It's a pleasure to be here.
And we also have joining us for the conversation, but via Zoom, Dr. Ganiyu Jamiu, the Chief Consultant Epidemiologist, Federal Ministry of Health. Many thanks for joining us, sir.
Thank you very much. Good morning, everybody.
All right, thank you, Doctor. And we also have Professor CFA Brisibe, the Commissioner for Health, the Bayelsa State, and co-chairman of the National Emergency Medical Treatment Committee for the National Emergency Medical Service and Ambulance System in Nigeria. Many thanks, Prof, for joining us.
Yeah, thank you for having me.
All right, thank you very much. Let's begin the conversation here from the studio. Let me ask Dr. Rufai, where are we with combating Mpox in Nigeria?
Yeah, thank you very much. Currently, we have a multi-agency task force, which was activated, the monkeypox EOC. In time past, it was deactivated when the cases are actually completely zero in Nigeria. As we stand right now, we know that 19 states are reporting out of 30 LGS. So there's the reactivation of this task force, which combines with the government, partners, and all of our international donors. It has become a public health emergency globally. So here we are, we have developed documents around how we manage this condition and disease, and what the public should also do. On the long term, vaccinations will happen, but in the meantime, it's also very important that Nigerians understand that, yes, this is a disease that has come, and it is infectious. It is in Nigeria. It is in all of the states, whether you are in northern or southern. No, it's what I mean by in all. It can, because of our migrant nature moving, so it can go to every state. So we have reports from 19 states already. You can imagine when it came, and it's already in 19 states. So yes. So we as the National Primary Healthcare Development Agency, we're collaborating with the NCDC, which is primarily mandated with surveillance for vaccine preventable diseases and all of the other diseases. So we're working with them in terms of developing IEC materials to be able to educate Nigerians, and also to increase our sensitizations at the local levels, beyond the federal level, the subnational levels, up to the interiors, the villages and all that. So we've also put in place measures at primary healthcare centers, which we have direct relationships to. We're conducting sensitization, we're doing screening for any suspected cases. We've been able to train health workers in terms of what this disease is about, what they should look out for. And yes, we have also designated some centers as referral centers for suspected cases where tests would now be conducted and a confirmation can now happen. And in these isolated centers, we now have what we call isolation units, where suspected cases are isolated, they manage until they get well for now. We all know that we received vaccines. For monkeypox, it was a donation from the United States government that happened on the 27th of August. And as we speak now, there's what we call a deployment plan for that vaccine. But what we're waiting for NAFDAC, who has taken some samples, to do some testing and to now give, they are the ones to give the go-ahead to say, yes, these vaccines can be used in Nigeria. So before the vaccines, it is important to put it out there that yes, the sensitization includes what needs to happen, what are the symptoms that if anybody sees, they need to quickly report to a health facility. And some of the symptoms were listed here. We have fever. This is not just fever, high-grade fever, 38.5 degrees centigrade, which is what they call high fever in common parlance. You have intense headache. Is really intense headache, body pains, the one and the doctors will call myalgia. Then on examination, found some lymph nodes. These lymph nodes usually do not get enlarged except there's an infection. For monkeypox, they promptly come out, and yes, so the health workers actually know what to do. So we're also advising the health workers also to make sure that they actually do what we call IPC, infection prevention control measures. Wear gloves. So now we have what we call the high index of suspicion. So somebody comes with a fever, normally Nigerians will come and say, I have malaria, just because they have fever, but not all fevers are malaria at present. So Nigerians need to know that. So our health workers look out for fever when they have anybody that has
Because
fever.
some can now present as Mpox.
Yes, exactly. So the fever could be as a result of Mpox. It's not necessarily malaria that Nigerians always do and go to one chemist to go buy one of those tablets and just drink. But Nigerians need to go and see a health facility worker to be able to ascertain that this is not malaria. And of course the rash, which is quite typical. You can't miss that.
Okay.
It's a combination of effort, and it's multi-sectorial right now.
Okay, I'd like you to give us, just a brief explanation of how this disease, manifests and all of that. And then, is it treatable? Because you're talking about isolation centers and all of that. Of course, we know, yes, transmission is possible, to other humans. And tell us how fast that is in terms of transmission. And if treatment is available in the country at the moment. And then you talked about training medical personnel. I want to know, are you training medical personnel in tertiary health facilities or those at the primary health care center? Because we know that a lot of people, their first contact with the health facility is usually the primary health care center. So if there's no enough awareness at that point, then we may have a crisis in our hands.
So I would start from, the disease. Well, it's well known fact that it's a zoonotic disease. What it means that the virus actually was discovered in animals and is being transmitted to humans. But now there is also the human-to-human transmission, which is by close contact, some respiratory droplets, body fluids. So it's also transmitted through sex, transmitted through kissing, and use of co-use of things like towels. So if one person, as individual, is infected and has some of these lesions and he uses a towel and another person uses it, especially that we'll never know. You can see some tiny breaks. So those body fluids can now, the virus is in the body fluids and now get transmitted to the next person. And yes, that happens. I actually listed some of the symptoms that you could see. So in terms of treatment, in medical terms we say, okay, it's manageable. So treatment is usually symptomatic. Try to bring down the fever using analgesics and treat the sores and make sure that the patient is as comfortable as possible. Make sure the person still eats, gets food and be able to maintain and also gets hydrated. That's also very important. So isolation is to reduce transmission. It's not to provide or to promote stigmatization. I need to bring that out because that's a major problem in Nigeria. Somebody has a rash and all of that, people start running around. And those rashes are pretty disfiguring, it looks like, this person, the way Nigerians have usually stigmatized all of this. So it's usually better when somebody is a suspected case. Before anything happens, it's best that the person is properly examined and test conducted and person now treated. Then the person can't be let go when it is confirmed that it is not monkeypox or it has resolved. Yes. And then in terms of your training, so I want to say this, as National Primary Healthcare Development Agency, I think we have the largest footprints in terms of structures beyond the federal level. So we have folks that we work with at the state level. We have also state primary healthcare board who are directly responsible for those primary healthcare centers in those states. So we work with those state structures to also be able to train these health workers. So yes, us health workers at the sub-national levels, at the primary healthcare centers, know these signs that they need to look out for. So we have aids that are on the wall, so in case you forget, you easily just check once you see a client coming in, and all of the other issues around IPC. So they're also trained on IPC measures to ensure that, yes, first things first, do not say, oh, this is my brother or my sister or my cousin. Please wear hand gloves, wear a face mask when talking to any patient at all. For the period that we're in right now, it's supposed to be a usual practice, actually, at IPC, at health facility, even at the homes, cleaning of surfaces normally. Just be hygienic. Wash your hands with soap and water. Yes. So that's where we are at. The workers at the health facility are trained. They have job aids to remind them. Then we have also activated structures in terms of surveillance. We built up surveillance to be able to detect from the communities, also from the health facilities.
Okay, Dr. Rufai, thank you very much for your opening remarks. Let's get to Professor Bresile, who's joined us from Uyo. Prof, your Commissioner for Health in Bayelsa, in addition, of course, to the national assignment that you have with the National Emergency Medical Service and Ambulance System. What's the situation specifically in Bayelsa, and how is the healthcare system dealing with it?
Yeah, thank you so very much for having me on this platform to talk about this. In Bayelsa, what after the early 70s, when Mpox, monkeypox, was discovered in Nigeria, the next time it was in 2017 when it became an epidemic level, and the index case was diagnosed in Bayelsa State. So somehow we're used to it. And then the other thing is that we have one of our infectious disease consultants that is at the forefront of doing this. So on the 14th of August, of course, our surveillance system has been a little bit quite okay. So on the 14th of August, when the World Health Organization declared this as public health disease of international concern, what we did was to see that we reactivate our public health emergency operational center. And of course, before then, from January to uh, 86, and out of this, of course, 5.
Looks like we have a connection challenge with the Honorable Commissioner for Health, Bayelsa State. When that is rectified or strengthened, would definitely get back to him. But let's get to Dr. Ganiyu Jamiu now. I want to find out, Dr. Ganiyu Jamiu, do you think that we should be worried about the clade, if you like, the variant of Mpox that we have with us? First and foremost, tell us the clade that is present in Nigeria, how it behaves, how fast it's likely going to spread, and what are the factors, that could aid this virus from infecting more people and, of course, spreading to more states. Do you think the weather condition is a factor away from, personal hygiene, which, Dr. Garba has already mentioned? Just let us know, all about the clade that is present in Nigeria at the moment.
Thank you very much. Whenever there is a new variant of a known viral infection, it usually causes worry, especially for the major stakeholder and for the country, at the global level. But you'll believe with me that this is not the first time we are responding to an outbreak of such nature. We've had experience before. Professor from Bayelsa mentioned the fact that we had an outbreak sometime in 2017 and up to 2022. So based on our experience, we think we're really prepared for this. It's just that based on epidemiological findings, it has proven that the current variant YA, the new variant class 1A also is said to be more common among men who sleep with men, and I want to believe that with that we are more. That shouldn't be a concern for us because we've had a lot of programs that actually take care of such category of people, and I want to believe that with the supply of this vaccine, it will go a long way in ensuring that those category of people and other high-risk group benefited from the vaccine after the approval from NAFDAC. So I think, and again, looking at our surveillance system, I want to believe that it is robust enough to be able to, capture whatever cases that may be coming up. Looking at the community-based surveillance, looking at the facility-based. We have two types of surveillance: the case-based and the indicator-based, which I think they are very strong enough, which are came into the IDS, and that is the integrated disease surveillance and response strategy that we have actually, implementing in the. I think we are more prepared, and one of the key things we did was the one of the another step taken was the using using the
All right, I think we're having a little jam at that end between the Zoom guys, but let's come back to the studio here where Dr. Rufai is still seated. At least there will be nothing like jam connecting with you. But talking about the vaccine, which Dr. Jamiu had talked about before we went off him, how much of it do we have, and is it likely to achieve the results that we expect it to achieve, beginning with the numbers?
Yeah, well, we'll start with the numbers that we have. So we had a donation of 10,000, around the figure. Some of that needed to go to NAFDAC for testing. So we have less than the 10,000, a little less than. So we had to give like 20 of those doses. So we have currently 9,990. Almost 10,000. So yes, that's what we have in country right now. And for that, we're not going to go all out to, at least currently, all out to do what we call mass vaccination for everybody. That will not be enough for our population. So based on the epidemiology and what the disease trend shows us, so those states that are mostly affected are the states, the Bayelsas, the Cross Rivers, the Ogun, the Lagos, and all of that.
Why are those states more affected?
That's where the disease has been seen. Having to go to why is not something you could place your hands on, but we would say that this disease, knowing how it is spread from animals and also the human contact, so it's possible that yes, we have folks who maybe handle animals more around in those areas. They're actually found from rodents. It was actually seen. Yes, it's monkeypox that was seen in the 50s, but however, the host for this virus is like a squirrel. That was what was found. But there's this interaction between animals within forest and all that. So yes, for folks who actually deal with animals, mostly that's where it is higher in terms of transmission. And you heard all of the other things around sexual behaviors, multiple sex partners, and all of that. So yes, so that comes to play also in terms of the transmission.
So those states that are likely going to get the vaccines, is it those who are already infected with Mpox that will get it, or those who have come in contact with those who have it?
Exactly. This is a viral disease, and it's highly infectious. So the major thing around surveillance, first thing first, is to first contact tracing. When a case is found, it's very, very important to do. What are the people that have been in contact with this individual? Where does he stay? Who are his friends? Who are his family? And all of that. So those will be the first
to be vaccinated.
To get vaccinated, so priority is given to them. Also, our health workers that are our first line of defense in case of any of these diseases. Also, it's also important. So part of the plan is to also vaccinate health workers and also contact on we do what we call ring vaccination, because we have very limited quantities for now for around that individual, families, close contacts, and all of that.
But how safe are these vaccines? Away from the testing that NAFDAC is trying to do, because there's this conspiracy theory about vaccines and Africans reducing population, using vaccines and all of that. This particular Mpox vaccine, looking at the source and how fast it's here and all of that. I mean, what's your reading of it, and what would you want to tell Nigerians?
I want to tell Nigerians to stop listening to non-professionals, to stop listening to mischief makers. So let me put, before this vaccine, before the disease was declared as a global health concern, we had already made plans for these vaccines to come to Nigeria. It's not like, because it was now declared that's where the vaccines come. No, we need to get that clear. We are already stockpiling this vaccine because we from the trend of disease of spread of disease, we're already seeing that monkeypox was in countries that were close by. And we know that these diseases, they don't make phone calls before they come to you. They just cross over. It's just one person that moves. We remember the Ebola issue. It was just one man, and it became a really big issue. So yes, there is no conspiracy to it. And I keep saying this. We've started this conspiracy theory in Nigeria from 2003. For the polio case, it was a really big case. I said it was going to cause infertility and all that. Where did that happen? In Kano. I'll ask the people of Kano. The children that took the vaccine in 2003.
How many children do they have now?
Exactly. We know how populated Kano is. I used to work in Kano. There are places you go to, you need to park your car because the children everywhere. So if this thing, if vaccines actually cause infertility, then I think we should go check what's happening in Kano. There's nothing like that. It doesn't happen. We know vaccines work. The science proves it. Smallpox has been eradicated because we use vaccine. It is clear.
Okay. But the numbers we have, just to make it clear, given your analysis, doesn't quite scratch the surface. By the time you deploy some for those on first line duty, you trace this and trace that, you probably have the whole 10,000 vanished.
Exactly. But that is not the end.
But why are we not getting more though? Why are we unable to access?
Why are we not getting more? We're making plans to get more. African CDC is supporting us to get more vaccines as we speak right now.
Will the vaccines be free?
Definitely, from the federal government, yes, vaccines are free.
All right, it's important to get that clear. Let's get back to Professor C.F. Brisibe. I'm sure you're back with us and you can hear us loud and clear. Prof, before the disconnection, you were trying to tell us what Bayelsa State is doing, and listening to Dr. Rufai, Bayelsa State has quite a number of cases of monkeypox. So tell us, what is going on in Bayelsa at the moment, and what's the government planning to do?
Yeah, okay, thank you for having me back. So presently we have 106 suspected cases in total, and out of that we've gotten 6 of them tested positive. So what we are doing is that we've reactivated the emergency public health emergency operations center. We have upscaled our surveillance, and also we've also procured PPEs and then also medical, essential medical commodities for treatment. We've also tried to see that our isolation center is functioning. But all this, we are doing it on 3 basic fundamentals, and that we believe that first, the first fundamental is that we want to stop people getting infected by engaging in advocacy to change behavior, to see people have what it takes, wash your hands, don't eat uncooked meat, and then, of course, because so we are doing that on that front. The second fundamental is that even when somebody has it, we must mitigate transmission, person-to-person transmission. So, and that is why we are deploying the PPEs and also educating our public and then health workers, retraining them. Then the last framework is that, look, even when we have this, if somebody is infected, we should keep it at 0 mortality, and of course the isolation wards, and then the disease surveillance framework that is active every morning, including One Health platform. We all have a conversation around what is happening, and then deploy these essential medical commodities to all our centers. And luckily for us presently, in all this, we are able to have the fact that
Prof, we honestly cannot explain what's going on, but I'm sure that all of that. Prof, looks like you're back with us.
Yeah, I'm back. Okay, so sorry for, So those are some of the things we are doing, and we are also grateful for the fact that presently we have vaccines distributed by the U.S. government, and we are also prioritized as one of the states that is going to have that. So we will also engage in that training and also advocate, because of course all of us understand the conspiracy theory around vaccines. So we need to advocate to our public, and then even the health workers, the frontline health workers, that we are going to prioritize in having these vaccines, that look, this vaccine is safe and it's not going to cause any problem. And of course, the government has been very, very supportive, because in all this, we've been able to mobilize funds to do what we're doing. If you get to Bayelsa now, the local jingles we have in our local dialects and languages to sensitize and also see that people's behavior in terms of getting hand hygiene come back, and also in terms of having meat properly cooked, and then of course preventing getting to people that close contact. So that all that is being done. We also believe that as we do all this, we must not stigmatize people, because of course these issues of stigmatization, even when cases are not confirmed. Once you just say this is Mpox, a lot of people tend to run away. We are also trying to see that does not happen, even as we preach against contact. But of course, the lesions, when you have them, the rashes, immediately after the treatment and you recover, you see that these lesions go. So some people also have this belief that these lesions are not to go to. We are also engaging all that as our treatment framework. So those are some of the things we're doing, and of course, like I said, it's basically to see that with any mortality, and then also mitigate person-to-person transmission as well.
Fantastic, Professor Presibe. Of course, we can see that, rather we can hear, we hope to see all of these actions in place. But you talked about the jingles, you know, in the different dialects. But you know that there are so many challenges as regards that. Just maybe a few people who have power supply and all of that may be able to hear those jingles. Are you in touch with community leaders, you know, the way Bayelsa is, you know, just so that those in the hinterlands who are likely going to be more affected if this gets to them, get to hear this message as fast as possible and understand it? Are you doing all of that? Are you getting health workers, you know, to reach out to people in their communities, you know, just to get them informed?
Yeah, you know, Bayelsa health system is one that's mainstream public health, and also we have a very strong buy-in platform that we have created in all our facilities, including the primary healthcare facilities and then the secondary healthcare facilities. We have what we call healthcare facility committees, management committees level, and then at the primary level we have the World Health Committees. These committees are made up of traditional leaders, opinion leaders, the head of this the facilities. Of course, it was basically created to ensure that we have uptake of these services provided by these facilities. Therefore, we are using that platform actively as we speak, and that is one reason why you see that in Bayelsa we have a high number of suspected cases. In fact, the whole state, the whole country outside Ogun State, we have the highest number of suspected cases. And the reason for that is because our communities, we are working with traditional leaders, we are working with our opinion leaders, the CDCs in our various communities. So we have a very high rate of patronage and turnout to these facilities in our communities. So that is also already something that we are doing actively. It's part of our framework, because the framework for us is that, look, we should be able to build a strong and resilient health system. Therefore, before shock, we operate, before any public health emergencies, anything, we operate maximally. And in case we have very serious public health emergencies, we should be able to operate minimally and restore immediately after those crises. So it's on that platform that we are doing all this. So the community buy-in, the community involvement, the leadership, opinion leaders is top-notch.
Professor Presibe, thank you very much for those comments. Let's quickly get to Dr. Jamiu, who also has joined us via Zoom. Taking a cue from Bayelsa, courtesy what Prof has outlined, what else should states do? Because when we are able to mitigate Mpox across states, then we probably won't have a national emergency.
Yes. I'm not hearing you, please. Can you just repeat it again?
Take a cue from Bayelsa. What more should states do? Because therein lies our capacity to deal with Mpox. If you're able to mitigate it at the state level, then dealing with it at the national level will be almost a foregone conclusion.
Yes, I agree with you. You see, what is happening in Bayelsa also applies to every other state. The capacity in pandemic response in Nigeria, the capacity of the state has been strengthened in terms of human capacity, laboratory capacity, surveillance, and other logistic-wise. So whatever you see happening in Bayelsa is not surprising to us, because that is what the government actually, our mandates, and as well as our target to see that state can manage outbreak on their own, which many states are able to carry down. This is example of what's happening in Bayelsa is not only that of Mpox. We've had cases of other outbreak like cerebrospinal meningitis, heavy metal poisoning, and so on. And states have taken that both step, that leadership to ensure that they manage it with limited support from the national. So I want to assure you that what is happening in Bayelsa is not peculiar to them. Other states' capacity have also been built to be able to manage outbreaks. So I'm not surprised with that. And I want to assure you that whatever is happening in Bayelsa is also applicable at the national level in terms of ensuring that we leave Mpox on board. And I want to make it very, very clear again on the issue of what you just mentioned. Yes, risk communication is very, very important. We need, and also, I want us to understand the fact that Mpox is not a new thing to us. It is something that is endemic in West Africa and Central African countries like Nigeria. And the report that was being shared, that's already been shared, and this data that they recorded from January this year today. So it's not that we are not aware of the fact that there is Mpox in the country. What we are trying to do, just like Prof said, is to limit its spread so that we are not going to record more cases with accompanying morbidity and mortality. And I think that is what the Nigerian government is doing in terms of surveillance and ensuring that all the necessary things are being carried out. Then I want to make it again clear that there is, if in severe cases there is availability of antivirals that can be administered to any severe cases to manage that, apart from vaccination. And also, we must try to make it very clear that the current variants are defined among levels people with men. And that is why we need to prioritize the category of people that will benefit from the vaccine. And one of those areas is those levels people with men. And I want to tell us, I came from the HIV angle before I became the current consultant epidemiologist. So we've been working in line with those program area that actually take care of those categories. That is the key population. And I think they will also benefit quite well as regards to that. Even the first case that was recorded in Bayelsa was in 2017. At the end of the day, we found that it was somebody that actually was involved in high-risk sexual behavior and so on. So I think we also need to critically look at those categories of people if actually want to reduce transmission. In addition to creating awareness and so on. And also our mothers are very, very critical because the virus can spread from mother to child. We need to take critical look at that. It's very, very important so that we make sure that we also protect our mothers from getting.
All right. Thank you very much, Dr. Ganiyu Jamiu. It was great to have you on the program this morning. Because of time, we'll leave the conversation at this point. It's a continuous one, and we hope we're able to deal with Mpox, just like we did with some other diseases as soon as possible. Thank you so much, Chief Consultant Epidemiologist, Federal Ministry of Health, Dr. Ganiyu Jamiu. Of course, Dr. Garba Ahmed Rufai, Director of Disease Control and Immunization, National Primary Healthcare Development Agency. Thank you so much for being our guests. We hope you continue to do your best just to keep the nation safe and healthy. Professor Siyefa Brisibe, Commissioner for Health, Bayelsa State, and co-chairman of the National Emergency Medical Treatment Committee for the National Emergency Medical Service and Ambulance System in Nigeria. Thank you so much for being our guest. And yes, we hope that the number of cases would reduce in Bayelsa. Thank you so much. So we'll take a break. The second leg of the conversation. It's on cancer. Stay with us.
The federal government of Nigeria wants vandals of national assets, electricity transmission towers, cables, and other facilities to desist from this act of sabotage. Vandalism is a serious crime punishable under the law. Vandalizing electrical equipment will affect millions of Nigerians, including your loved ones. Remember that national assets belong to all of us, hence the need to protect them. Report all cases of suspicious movement around electrical facilities to security agencies. When you see something, say something. This message is from the Federal Ministry of Information and National Orientation in collaboration with the National Counter-Terrorism Center, NCTC, Office of the National Security Advisor.
Did you know that President Bola Tinubu has approved the suspension of import duties and tariffs on rice, maize, and other essential food items for the next 5 months? The President has also approved the suspension of import duties on pharmaceutical raw materials and equipment. This will help bring down the prices of food and drugs across the country. All hands are on deck to ensure that things get better for all Nigerians. This is the renewed hope.
Meet lovebirds Jayola and Adama Davies. Their dream of living together as man and wife has finally been fulfilled.
The latest couple in town. Meet some Mr. Giant
But an invasion by their troublesome families was not a scenario they bargained for. A mother moves in. His mother shows up with his little niece. Then her younger sister joins the scramble.
You want to stay?
Married life suddenly becomes very complicated even before it started. Follow the story on this channel as they confront every challenge as it comes. Family forever, the story of our lives.
The counsel of our fathers.
My advice to these young people is please do not take us back to those harrowing days. You probably do not know what it is.
Nigerian youths, let's build our nation together.
We develop a nation where every citizen is given his due right, there is transparency, honesty, and integrity.
Put the interests of this country first and foremost. The interests of Nigeria is being one nation, one people.
We need, if I'm to put things right, things that have gone wrong before, to try and put right. For the love of country. Okay, so this is still Good Morning Nigeria on the network service of the NTA. Let's now turn our attention to cancer. Now, the cancer burden on Nigeria is quite, huge, and the disease, accounts for 13% of all deaths in the country.
Actually, about 15% thereabout. Now, that's actually true, Victor. And the most common types of cancer in Nigeria are breast, cervical, prostate, liver, and colorectal cancers.
Well, cancer incidence and mortality rates are increasing in the country due to the growing population, aging, urbanization, changes in lifestyle and diet, as well as limited access to screening and early detection.
Cancer is a difficult disease, so don't blame me. I find it difficult to call that. Now, data on cancer has been a major challenge in Nigeria due to inadequate cancer registration and data collection systems, limited availability of reliable and up-to-date cancer data, of course, in so many areas of concern, as well as underreporting of cancer cases and deaths. And, of course, you want to talk about the lack of standardized cancer data collection tools and protocols. It's a whole mix.
So as Nigeria grapples with the rising cancer burden, access to accurate and timely data remains a significant challenge. Inadequate records and lack of awareness have hindered effective diagnosis, treatment and policy making. But it is important to mention that the World Health Organization offers cancer data and statistics for Nigeria, while the Nigerian Ministry of Health
publishes occasional reports on cancer data and initiatives.
Key statistics on cancer in Nigeria estimate that in 2020, 115,000 new cancer cases were reported annually, with an estimated 70,000 cancer-related deaths annually in the same year. Now, cancer incidence rate indicates that about 120.2 per 100,000 population in the year 2020, and cancer mortality rate of 90.7 per 100,000 population in the same 2020.
And one thing to note is that data may vary depending on the source and year. We'll examine the role of technology, advocacy, and policy in enhancing cancer awareness and care.
Join us. We have joining us to speak on this, Professor. We're supposed to have the DG of NICRAT, but due to some other pressing issues, he's unavailable. But we have with us Professor Musa Ali Gombe, the Director of Clinical Services, NICRAT. Many thanks for joining us.
Good morning, viewers.
I have also been joined via Zoom from Bauchi by Professor Sani Malami, Director of Cancer Surveillance and Monitoring of NICRAT. Thank you for joining us.
Good morning.
Well, let's begin from here in the studio. Professor Ali Gombe, where are we? We do know that most people who, it's almost like a death sentence. When you hear that someone has cancer, people begin to say, yeah, because it leads oftentimes, to one end, death. No matter how hard, no matter how much you have, by the way. But where are we, and how can we begin to ensure early detection so that more people can survive cancer?
Okay, thank you. Before I go to your question, I will want to tell the viewers a little about the institute itself. The National Institute for Cancer Research and Treatment, which is NICRAT, was established by the establishment of 2017. However, a substantive DG was not appointed until February last year. So it's a new institute that is, some people may not be conversant with it. And what is the mandate? The mandate is, the NICRAT is majorly created to take leadership in cancer prevention, diagnosis, treatment, and control in general. It also has the mandate to liaise with anybody in the cancer space in Nigeria to coordinate and also execute the implementation of cancer projects in the country. In short, the vision of the institute is to take leadership in not only Nigeria but also in Africa at large. So, cancer is not a death sentence, actually. However, for most cancers, one needs to present early. That is why screening is very important. Early detection saves lives because cancers are in stages, stage 1, 2, 3, and 4 in most cases. So stage 1 and 2 are called early cancers, while stage 3 and 4 are called late cancers. So early cancers, the chance of cure is very high. It usually ranges between 70 to 90-something% depending on the type of tumor that one has. And also, for the late advanced cancers, the chances of cure decreases. However, irrespective of the stage of the cancer, the chance of cure is still there. And I can tell you that there are even stage 4 cancer patients that have had cure. However, screening is a very important tool. When you look at the burden of cancer that we have in Nigeria, if we will be able to screen early, it is more cost effective and it will reduce the mortality of cancer that we have. So what is the Institute doing? The Institute has a dedicated department, which is the Department of Cancer Prevention and Control, which is under the responsibility of screening and early detection of cancers. The Institute has gone ahead to design and plan some screening programs for the country. We have observed that, one, there is need for advocacy. So people need to know what is cancer and demystify the myths, that people have about cancer. and also take advocacy to other stakeholders in the cancer space. And another factor is collaboration. You need to collaborate both locally and internationally for you to succeed in cancer screening and cancer control in general. The other aspect also is in terms of what do you do for screening. Currently, there is no comprehensive national screening guidelines and comprehensive national screening programs in the country. So we are already developing a national screening guideline, most especially for the common cancers, breast, cervical cancer, and prostate, and then cancers of the children, as childhood cancers or pediatric cancers. And also, we have identified that there is need to do a two-pronged approach to the cancer screening in the country. Based on the tertiary institutions that do treatment of cancers across the country, which are at least, you have at least one in each geographical zone, that can be made to be the hub for cancer screening at the tertiary level. Meanwhile, we have also designed a mobile clinic, which we are trying to launch for screening into the population, whereby you can go to the community and screen based on some criteria. Probably you may decide to choose maybe the market days, for instance. So the mobile clinic is a van that will be equipped with the screening tools, equipments that are required for screening the commonest cancers like breast, cervix, and prostate. That goes into the community, screen, and then returns the sample back into the laboratory. But another dimension to it also is the personnel, that we require for the screening. Apart from the supportive staff, the specialists that we interpret those screening results, such as the radiologists and also the pathologists, are actually very few in the country. And so we also thought that deploying artificial intelligence as a component of the screening can also assist in reducing the burden for those few pathologists that we have, radiologists in the country, because that will AI can be used actually to select which patient goes for review by the doctor and then which patient does not require review. The other aspect is also to take the screening at the primary care health level. So there is also need to screen, to train the primary care staff in terms of detection of early symptoms and signs of these common cancers, so that they can navigate the patient appropriately to where the patient can receive treatment.
All right. Many thanks, Professor Gombe, for your opening remarks. Quite detailed. Shows that NICRAT is doing a lot. But let's get to Professor Malami, Director Cancer Surveillance and Monitoring at NICRAT. Prof, I want you to take off from where Professor Malami stopped and tell us about the challenges around cancer in the country at the moment. We want to know, is it the lack of personnel, like Professor Gombe had mentioned, or is it the lack of infrastructure, to deal with it, or is it an issue of culture, people wanting to run away from saying, oh, well, I can't have cancer, and, not wanting to present themselves to medical personnel and all of that for screening and treatment. Just let us know, why are the numbers rising and the factors responsible?
Thank you very much for that question. My colleague has given a very good background as to the cancer problem in Nigeria. Specifically to respond to your question, cancer is a multi-dimensional challenge in Nigeria, in the sense that it continues to rise. Our approach as a nation, as various communities, as professionals, have clearly been ineffective in this, over the past decade. We've seen a steady rise in the number of cancers in Nigeria, and which is unfortunate in the sense because, of course, we have a very weak health system. We have limitations in terms of resources in Nigeria, which Professor Gombe has mentioned. personnel, equipment, I mean, the whole gamut. So, talking about cancer, one has to approach it from this perspective. We are in Nigeria, we know our limitations. So, what can we do? We know for a fact that about 30% of these cancers can be prevented by just adopting lifestyle changes, avoiding certain exposures and the like. About 30% can be prevented by detecting them early and treating. And then the other 30% are amenable to various forms of treatment. So it's not, as my colleague has said, it's not a death sentence as many people assume. And this is the information we need to get out there. Let people know that cancer can be controlled, and there are various steps being taken by government and other partners to see that this is controlled. But we need the cooperation of the society itself. We need to marshal our resources to consolidate what we are doing in very many ways. So talking about cancer as a disease, most people assume that cancer is a disease like probably like typhoid. Say this is typhoid is caused by so and so. Bacteria, and this is not the way cancer is. Cancer itself is a whole range of many diseases. Cancer that affects for instance, the breast is very, very different from the cancer that affects the brain, affects the bone. You know, in terms of the position, in terms of how it manifests, in terms of the effect it's going to have on the individual, in terms of the ways to approach it and treat it. And so the investment has to be, in order to approach, to treat it, the investment has to be a targeted kind of one, a knowledge-based. There is a lot of things that come into that picture before we're able to approach cancer. So one of the, that's where we are lagging behind as a nation is in terms of data, which is the subject of our discussion today. We don't know for a fact what we are treating. We don't know how many cancers, we don't know who is being affected, we don't know where people are being affected, we don't know how they are being treated, we don't know how they are responding to this. So apart from the fact that we have a serious problem, a problem of equipment, a problem of personnel, the right skill sets, the right infrastructure for the treatment, we also unfortunately do not know, we do not have that data.
Lost connection with Professor Malami temporarily. I hope we get it better and we reconnect with you. But let's get back here in the studio. Professor Malami had talked about data being an issue, but I'm also looking at screening, because if we say we can, according to him, 30% can be dealt with early screening. So how many screening centers do we have across the country? And what are the plans to improve this so that, because the more people can get screened randomly, then you know, oh, this person has a cancer that he himself or she may not even know about. So how many screening centers do we have, and what are we doing to maximize this?
Well, thank you for that. The issue of screening and data are separate things, but they are related. But let me answer your question first before I talk about the data. So in terms of screening, what is obtainable today in this country is that we have hospitals across the country in almost each state and major cities across the country, whereby if you want, you can willingly walk into these centers and ask for a screening.
How affordable? How affordable?
Well, it depends on the type of screening. Some screenings are more affordable than others, depending on the sophistication. And, for instance, screening for prostate cancer is a blood sample that is taken, and then an examination also a physical exam is done to the man who presents himself for a screening of the prostate cancer. It's relatively cheaper when you compare to a mammogram for breast cancer, which is required for women over the age of 40 years to do yearly as screening too. So it depends on the hospital. Mammography machines are usually found in tertiary hospitals and some private clinics and diagnostic centers across the country. So screening is now done based on a hospital basis, not like a national coordinated program for cancers. And that is what I was mentioning earlier. There is need to coordinate it centrally and make the screening, a program whereby, anybody that wants to be screened can walk into a hospital. So what we did is to designate some hospitals across the country whereby we will do preventive oncology clinic. So those preventive oncology clinics are going to be responsible for screening, whereby if you just walk in, you will can request for screening for any type of cancer, and there are doctors, nurses, and other staff available to screen you. And we will also equip those centers with those necessary equipment and other things that are required for the screening of those centers. So that's for the preventive oncology clinic. The other aspect of screening also is you have to reach to the population, because if you stay in the hospitals, most people will not want to come, probably for several reasons. It's expensive to make the journey to the hospital probably, or their schedule is too tight to actually allow them come. Since they are fine, they may feel it's not necessary for them to come to the hospital for any screening. So it's also good to take the screening to the population. So that's why I have to go to the community where people are working, to the villages, in their farms, and to marketplaces and other places necessary to conduct those screenings.
Now, listening to you, Professor Gombe, who do you want to blame for the lack of data? Because you have mentioned the fact that, well, individuals cannot, be available at medical facilities all the time. The cost of doing the screening, of course, is also another issue. You're the ones who want to blame personnel, because sometimes they're part of this problem. Sometimes patients present, or rather get to them, and they're not able to detect that they have cancers. They keep pushing them up and down, treating all kinds of ailments before, eventually at a later stage they get to realize. So it's a whole chain. So how do we get this data issue right in a country where even the population of its people at the moment was still, just speculating?
Well, when NICAD came above and the DG actually, he swung into action, and the first thing that we did was to do a gap analysis. Where is the problem with the data in Nigeria? So we identified some very important factors. One is the issue of ownership by government. The cancer data needs to be owned by government. In the past, what happens is that some individuals have made very good attempts to get grants to support those cancer registration in Nigeria. However, it's not led by government. It is led by private individuals, and it's not housed, in government facilities. So what we did was to make the headquarters, we dedicated a section of the headquarters of the National Institute for Cancer Research and Treatment as the National System of Cancer Registry headquarters, whereby all cancer registration data will be pulled to that National System of Cancer Registries at the headquarters. This has already been launched about 3 months ago in NICRAT. And also we identified that the number of population-based cancer registries that we have. Cancer registries can basically be population-based or hospital-based. So most of the data that we are getting from the country right now is gotten from hospital-based cancer registries. They only record those patients that come to the hospital and are diagnosed with cancer. They are not going to the population. We have about 13 population-based cancer registries across the country. So these population-based cancer registries are supposed to be equipped to go into the population and take cancer data from all patients that are diagnosed with cancer. So that we have identified, and currently we have started equipping those population-based cancer registries to make them stronger so that they can have all the facilities necessary to do that. The other thing is also about the training of the personnel. We have also identified that a large number of our parents are not well trained to. There is a system, there is a software, there is a coding system, and the way you also fill in those informations is standard. So there is need to also train those people. So what we did was to do a national population-based cancer registry workshop, whereby we invited very important and personalities from across the world who are renowned in cancer registry data. Notably is the head of surveillance of IRE, that is International Agency for Research on Cancer, Freddie Bray, and also Professor Max Donald Parkin of the African Cancer Research Network, who is very popularly known as the main person behind most of the cancer registration across the world. So they came to the cancer research workshop in Nigeria, whereby they now step down some of this training to the directors and other staff of registries. We invited them to Abuja, where we had that workshop. And at the end of the workshop, another thing that we also identified is that people are reluctant to report cancer data. So there is also need for regulation to allow reporting, to make the reporting of data compulsory in the population, cancer data, because I may be in my clinic and I diagnose cancer. If there is no regulation, I don't owe anybody a duty to actually report this information that I have diagnosed this cancer patient in my clinic. So the Honorable Minister of State for Health, at the end of that cancer registry workshop, launched the cancer registry data regulation and also declare cancer a notifiable disease. So it is now compulsory in Nigeria when you diagnose cancer to report it. So that will also improve the cancer data. The other aspect that we also identify is in terms of infrastructure. Of course, if you want to do a population-based cancer registry, apart from computers, space for the staff in the hospitals whereby the registry can reside, there is also need to have mobility, cars or any other means of transportation for them to go into the community. Somebody has to pay for all those things. So these are things that we are trying to bring so that these people can be able to go reach out into the community and get those information for us, which can now be centralized into the cancer registry data. Another problem that you identify, which cannot be solved at an accurate level, is the issue of population the census, because what is currently available, if you look at the recent data that was released by Globacom, it's actually they use the 4 population-based cancer registries in Nigeria, and then they now do an estimate. But that estimate will have to depend on the population that you have. Since we don't have a recent population data, it becomes difficult to have an accurate estimate that you want to do. So that we have started advocating and reaching out to the players in the population space to also move so that we can have a national census that can also help in having more accurate estimates for the cancer data in the country.
All right, thank you very much, Professor Ali Gombe. Let's get back to Professor Sani Malami, who I understand is back well connected. Professor Malami, I was just wondering, while your colleague spoke with us, to what extent do you deploy technology in your operations, and to what effect?
Yeah, thank you for that question. Nigeria, in fact, the world has moved on from the days of manual registration. Now people are able to record data on cancer precisely accurately and also in a very effective way, and they're able to disseminate this kind of information in real time. For instance, part of the initiatives by NICRAD now is that we have set up a national database which can be accessed at any point from anywhere in the world. So technology is playing a great role in the evolution of cancer registration. Now in other countries, and we're hoping to reach there soon, people are able to report using their Android phones. They're able to report from very remote locations. They're able to collect data from in very vast countries like India, where they have hundreds of cancer registries, and these cancer registries collect information from thousands, I mean literally millions of clinics and hospitals. And this is done, of course, not manually, it's electronically. We have a software, which is an open source software called the Courage software, which is a software that has been developed by the World Health Organization, WHO, and it is compatible with most devices, Androids and other iPhones and the like, and it's compatible it can be used offline and online, and it's such a robust software, and now it is being deployed across Nigeria. We previously had the earlier version, the Courage 4. We moved on, now it's the Courage 5. All our cancer registries to be able to use the Courage 5 software. In fact, it's in recognition of the importance of technology in the work we do in the cancer registration space that IRAC, that is the agency of the WHO, which is in charge of data registration, is in the process of training 2 of our registrars in Lyon, France, and the training will start in October. They are going to be trained as master trainers on Courage, which is the top technology software for this. In addition to that, we are looking beyond what we are doing. In the near future, the Honorable Minister of State will be engaging with a Progressive Cancer Center in the US to explore also how we can use technology not only to have the data, the numbers, but also to be able to save the images, digital images of cancers, to tie them up with this. And this will give us a comprehensive picture of what we're looking at. So technology is playing a big role in our advancements. It's going to occupy a big space of what will be done. And technology is in fact going to dictate how the evolution of cancer registration is going to be now and in the near future. But the government is investing a lot in this area, and our partners will also be investing quite a lot to deploy technology into the cancer registration space.
All right, so thank you very much, Professor Malami, Professor Gombe, Ali Gombe. You have mentioned so much that NICRAD is doing, and then you did mention that it's a new organization and all of that. We understand the challenges that it could be. But tell us, what are the challenges, facing cancer research and treatment in the country at the moment? Are we thinking homegrown solutions, or what is NICRAD looking at?
I'll still go back to the issue of data, but now not only on cancer patients or diagnosis, but also what resources do we have in cancer. Based on that, the Honorable Minister of State for Health last year, November, has written to the National Atomic Energy Agency requesting an impact review to be conducted for Nigeria. The impact review mission actually is supposed to assess our resources, in terms of cancer prevention, cancer control, cancer diagnosis and treatment. And then it will also make recommendations so that at the end of the day we have a bankable document which we can use to inform the national cancer control plans, and also use it to see where we can invest in cancer care. So having done that, the minister also went ahead to inaugurate the national focal team for the impact review mission. The National Focal Team has been inaugurated, and the impact team, focal team is also working with the international team of experts and the IAEA on the impact review mission. The impact review mission is scheduled to take place in October, between 14th to 25th of October. However, there is a lot of work going on already. You know, there are some self-assessment questionnaires that we have been distributing across the country to assess human and other oncology treatment resources across the country. So this is in preparation for the impact review. The expert teams will come and they will visit cancer treatment centers and other cancer-related centers to assess our capacities and also produce that document at the end of the day. So that will give us a very clear view of what is obtainable on ground and what are the gaps, and then where we need to invest. But prior to that, some preliminary, we have done some preliminary work actually to assess, our capacities. For instance, what are the numbers of oncologists that we have in the country, the number of nurses, the numbers of medical physicists and retired radiographers, which are also important in treatment of cancer using radiation. So, because that will inform, and there is a ratio, standard ratio between the number of cancer cases that you have in the country for each personnel or each category of this healthcare personnel that you have. We know that we are very far low behind what is recommended internationally, and also the number of equipment, the number of radiotherapy machines versus the number of equipment. So, but what is the government doing currently with respect to all these things? One, I already mentioned, you need to actually assess properly to know what is on ground, which is what we are currently doing with the impact review mission. The other thing is, while this one is taking place, some things need to be done urgently based on these numbers that are coming out from the cancer reports. So the number of oncologists currently in the country is about less than 80 that we have. That is those that are trained in the art of radiation and clinical oncology. And with this JAPA syndrome, a large number of the oncologists are still moving out of the country. So there should be a way to produce more oncologists and also a way to retain those ones that we are doing. So the National Institute for Cancer Research and Treatment has started engaging the postgraduate medical colleges, and also the National Sovereign Investment Authority. We are about to have an NICRAT NSIA Oncology Summit, which is going to address oncology workforce in Nigeria. And we are mainly inviting stakeholders that are involved in training of the oncology workforce, training for nurses, training for doctors, training for the radiographers, training for medical physicists. These are the major players in the space, because you need to find a way of addressing some of these problems. Apart from the numbers, for instance, the medical physicists are not registered in the civil service. There is no cadre for medical physicists in the civil service. What they use is the scientific officers. So there is need to also have a medical physics cadre and a career pathway. The cancer registrars don't have a career pathway. So these are some of the things that we also need to address.
Is that why they're exiting the country?
Not necessarily. There are several reasons why people exit this country, and I believe, for personal reasons or for maybe some personal gain.
In your own view, what would be the way to retain some of these oncologists?
Well, we will have to first look at why they are exiting the country. It may be the remuneration why they are exiting the country. So we need to actually find a way of compensating the oncologists. You can imagine you have less than 80 oncologists that will attend to almost 130,000 cancer cases. The ratio is very high. They are overburdened. There was a study that was done by one of the oncologists to assess burnout syndrome in oncologists across the country. The reports of that finding was that all oncologists in Nigeria have burnout.
All right. So, but this applies also to other fields of medicine. And the solution, if the solution becomes that more people leave, it only intensifies the burden?
Yes, so there is need to have some incentives for those working in the oncology space so as to retain them in the country. And also, in oncology, work also entails probably going to, some of these remote places because there is need for some people to go and do screening and other things. So there's also need to put things in place that will retain those people even at the remote. Not all the oncologists that we assessed, even less than 80 are in the urban areas. None is in the rural area. So another thing that also needs to be done actually is to sub-specialization. The surgeons need to also sub-specialize in oncology. Also the gynecologists also need to.
Because we are running out of time, I hear loud and clear, and I'm sure that those who are in position to deal with it are also listening, that sub-specialization in oncology is very important. We have just a couple of minutes, and I hope we can get Professor Malami to give us his closing remarks, and perhaps you want to look at how where you see cancer, the data collection, research, awareness, and treatment in the next, say, 2 years.
Yeah, thank you. We are privileged to work with the minister and the team currently, which is highly focused, are taking all the right places. Dr. Tunji Alasa has been an extraordinary force behind our success. And from October last year, when the National Cancer Control Plan was launched today, which is about a year, we have covered a phenomenal distance, to be sincere. We see ourselves in the next 5 years, which is our target. The 2027 would be the end of the 5-year plan. We see ourselves able to celebrate certain milestones. For instance, we are hoping that with the initiatives on cervical cancer, as you are aware, the minister has just constituted a committee headed by a very distinguished Nigerian, Professor Adiole, to lead the national effort to control cervical cancer. This is one of the major contributors to death due to cancer in Nigeria, and there is a WHO World Declaration to eradicate cervical cancer within the next 5 years, and that is by the year 6 years, sorry, by the year 2030, and we see Nigeria being one of the countries that is going to be at the forefront of this fight with the formidable team that the minister has constituted. Not only that, we see an awareness strategy where the country will be creating a lot of momentum, creating passing the right messages, and this will transform the whole landscape in the sense that more resources will be mobilized, more resources will be deployed into cancer control in the near future, and this will make all the difference. We think.
All right, of course, we're looking out for all the difference being made, by all those involved in this fight. Thank you so much, Professor Sani Malami, for joining us for the conversation. Director, Cancer Surveillance and Monitoring at NICRAT. We do sincerely appreciate you for your thoughts and insight on the program this morning. Right, of course, Professor Musa Ali Gombe, Director of Clinical Services, NICRAT. It was a pleasure to have you on the program.
Thank you for having me.
All right, so, and we hope to celebrate your successes with you in the next 5 years, like Professor Malami said. All right, so that's good morning, Nigeria, this Friday. Take care of your health, very important. I'm Henry John.
All right, I'm Victor Azo. Thank God it's Friday.